Hey guys, what's going on? My name is Dr. Susan Kafle and today I'll be discussing about the midbrain syndromes. If you have not watched my video on red nucleus and the light reflex, accommodation reflex and the vertical case, I highly suggest that you do that first. So without the delay, let's begin. In this video, I'll be discussing about 5 different syndromes of the midbrain, the Weber syndrome, Benedict, Claude, Knoth-Nagel, and the Perinaud syndrome. So this is a photo that I've taken from my previous videos. As you see over here, the midbrain, it is largely supplied by the posterior cerebral artery, and we have the involvement of this artery in all of the midbrain syndromes. Now the brainstem can be divided into the right and left halves by this vertical line and into 3 different regions, the midbrain pons and the medulla by these horizontal lines, and each half can be divided into the medial and the lateral sides. When we are talking specifically about the midbrain, there are cranial nerve nuclei number 3 and 4. I've just mentioned 3 over here because the content of this video, the different syndromes, they basically involve the cranial nerve nuclei number 3. We have different tracts in the medial side of the brain. The 3 major tracts are the 2 of them are the descending tracts and 1 is the ascending tract. The ascending would be the dorsal column medial lemniscal pathway that brings the fibers from the spinal cord that take a sit at the caudal medulla over here and then ascend towards the cortex, bringing the sensation of fine touch, proprioception, pressure and vibration from the dorsal column of the spinal cord. And the 2 descending tracts we have is one of them is this corticospinal tract, which decussits at the caudal medulla to reach the other side, and the other one is this red one, so that is the corticobulbar tract, which is basically the upper motor neuron of the different motor cranial nerves. Now this is a section of the midbrain at the level of the superior colliculus. Midbrain can be divided into 3 regions. This is a cross section, so the 3 regions would be the tectum at the back, so this is the posterior side and this is the anterior side. So on the posterior side we have tectum, in the middle we have the tegmentum, and the most anterior would be the crus cerebri. This one at the middle, it is where the CSF is flowing, the cerebral aqueduct, and this one is the aqueduct, and the surrounding area is the periaqueductal gray. Right. So since this is a section at the level of the superior colliculus, I've written SC at the back. The fibers that were ascending from the spinal cord, the dorsal column medial lemniscal pathway, is lying on the lateral side of the midbrain. In the front we have substantia nigra, in the middle we have the red nucleus, and most anteriorly on the crus cerebri we have the corticospinal and the corticobulbar tracts. And at the level of the superior colliculus we have 2 different nuclei of the 3rd cranial nerve. I just highlighted the motor nucleus over here just to make things easy. At the level of the inferior colliculus we don't have the 3rd cranial nerve nuclei, we rather have the 4th cranial nerve nucleus, and there is no red nucleus over here. You can see that there is this structure in the middle, so these are the decussating fibers from the superior cerebral peduncle. Remember, the fibers from the superior cerebral peduncle, they originate in the cerebellum and then they ascend towards the midbrain, as I've discussed in my video on the red nucleus. So these decussating fibers they lie at the level of the inferior colliculus, right? So now let's highlight the key midbrain syndromes in different areas of the midbrain. I've just drawn this at the middle of the midbrain to denote the decussating fibers that are coming from the cerebral peduncles, superior cerebral peduncle to be accurate. So these fibers decussate and reach the red nucleus. Now the first syndrome that we have is the Weber syndrome, that is involving the corticospinal corticobulbar fibers and the third cranial nerve fibers. The second one would be clot syndrome, which involves the red nucleus and the third cranial nerve. The third one is the Benedict syndrome, which involves the red nucleus, third cranial nerve, substantia nigra, and anteriorly it also involves the corticospinal and the corticobulbar tracts. Fourth one is the North-Nagel syndrome, that involves the third cranial nerve nuclei and the fibers that are crossing towards the red nucleus. And the fifth one is the Perrinot syndrome, which is basically a lesion at the posterior side of the midbrain, compressing the midbrain from the back. Now let's discuss each syndrome one by one. So in Weber syndrome, since the lesion is on the anterior side, we have the involvement of the corticospinal tract leading to contralateral hemiplegia. Then we have the involvement of corticobulbar tract leading to contralateral paralysis of the lower face. And we have the involvement of the third cranial nerve, which leads to three things. Remember, whenever there is involvement of the third cranial nerve, there will be basically ptosis. The pupil will be down and out because the eyes uh, they have extraocular muscles. Most of the extraocular muscles are supplied by the third cranial nerve, except lateral rectus and the superior oblique. We have this mnemonic LR6SO4. Lateral rectus is supplied by the sixth cranial nerve, and the superior oblique is supplied by the fourth cranial nerve. So since we are losing the supply to the eyes via the third cranial nerve, the medial rectus will be paralyzed. So for example, the right eye is involved and the medial rectus of the right eye is paralyzed, and the inferior oblique is also paralyzed. So inferior oblique and the inferior oblique helps to elevate the eyes when adducted, and medial rectus helps to keep the eye turn the eyes towards the medial side. So since these two movements won't be occurring, so we'll basically have more of the activity of the lateral rectus. The eye would move towards the lateral side, and since the inferior oblique is not elevating, it would rather get depressed and the pupils would be down and out. All right, and then there would be mydriasis, or the dilatation of the pupils. So these three are the features of the Weber syndrome. Now we have clot syndrome, which affects the red nucleus and the third cranial nerve. Because of the involvement of the red nucleus, we have contralateral cerebellar ataxia, because the red nucleus is receiving the fibers from the superior cerebellar peduncle on the contralateral side, like you can see the cross over here. So it will lead to ataxia and tremor. This tremor is the intention tremor. Whenever we have the involvement of the cerebellar fibers, we always have intention tremors. Also in clot syndrome, you see that the third cranial nerve is being involved, and again we have ptosis, down and out pupil, and dilated pupil. In Benedict syndrome, we have the involvement of this red nucleus leading to contralateral cerebellar ataxia and intention tremor. Then we have the involvement of the third cranial nerve, which leads to ptosis, down and out pupil, and dilated pupil. Then we have the involvement of these fibers, the corticospinal and the corticobulbar fibers, leading to contralateral hemiplegia and paralysis of the lower face. And then the substantia nigra is also involved, leading to contralateral resting tremor. You might have heard substantia nigra in relation to Parkinson's disease. So one of the features of Parkinson's disease is resting tremor. So if you see over here, there is intention tremor as well as the resting tremor on the contralateral side. So when both of these tremors are present, the tremor is called Holmes tremor. So Benedict syndrome is characterized by Holmes tremor. In North-Nagel syndrome, we have the involvement of the fibers that are crossing towards the red nucleus from the superior cerebellar peduncle. So there would be contralateral cerebellar ataxia and intention tremor once again. And then the third cranial nerve involvement is there, leading to ptosis, down and out pupil, and dilated pupil. Perrinot syndrome occurs when there is compression of the midbrain from behind. There is a tumor like pineoloma that is compressing the midbrain from behind. So it is basically compressing the structures that are present at the posterior side. So one would be the pretectal nucleus, because the compression of the pretectal nucleus, and the other is the other is the fibers that are crossing in the midline. So what fibers are crossing in the midline? One is the fibers from the pretectal nuclei that will result in loss of light reflex. Remember, pretectal nuclei are involved only in the light reflex and not in the accommodation reflex, which I have discussed in my previous video. So there will be loss of light reflex but not the accommodation reflex, and so the eyes can uh, accommodate but not react to light. So that is called the light near dissociation. The other fibers that are crossing in the posterior midbrain are the fibers of the rostral interstitial medial longitudinal fasciculus. If these fibers are involved, there will be upward gaze palsy, and we refer to this as the sunset sign. Now, apart from the crossing fibers, there are also the inhibitory fibers to the third, fourth, and sixth cranial nerve nuclei, or the different nerves that are supplying the extraocular muscles. These inhibitory fibers are also present on the posterior side. So as the inhibitory fibers to these different cranial nerve nuclei are lost, one of the things that will happen is there will be loss of inhibition to the muscle levator palpebrae superioris. So that would lead to retraction of the eyelids, over retraction of the eyelids, and we call it as the Collier's sign. Now the other thing that will happen is the inhibitory fibers to the medial rectus and lateral rectus will also be lost. Medial rectus is supplied by the third cranial nerve and the lateral rectus is supplied by the sixth cranial nerve. So whenever you try to, this will lead to convergence, retraction, nystagmus. Let me tell the concept behind this. So the medial rectus is trying to pull the eye towards the center or the medial side, and the lateral rectus is trying to get the eyes away from the center, so that is towards the lateral side. So whenever basically this convergence, retraction, nystagmus you will see when you ask a person to look upwards. The upward gaze will be paralyzed, but when the person tries to look upwards, the other nerves that they start firing without any inhibition. So the medial rectus as well as the lateral rectus will contract more. All right, so what happens is medial rectus tries to bring the eye towards the center, so that means that there will be the eyes will try to converge, and retraction means that both of these muscles, these are trying to pull the eyes from either side. So that would lead to the eyeball retracting in the orbit. It will feel like the eyes are going back into the orbit. So that is called retraction. The term we call is the convergence, retraction, nystagmus. So in Parinot syndrome, we basically have these four things: the light near dissociation, upward gaze palsy, Collier's sign, and convergence, retraction, nystagmus. That's it for this video, guys. I hope that you understand the different syndromes. uh, I'll see you in the next video. Have a great day. Thank you. Bye.